So information on CMEs, and I nor anyone on the hub team have any financial arrangement related to what we're going to be talking about today, so nothing to disclose. I'm going to be sharing a little bit of information on the stages of change model and the spirit of MI. So the hope is to just be able to help those that may not be as familiar or not familiar at all with the trans-theoretical model of change and how that applies to working with patients with substance use disorder. So really, what is that model, and how can you use it to make the best match of treatment recommendations for the patients you're working with? I also want to talk a little bit about where MI comes into play, why this is valuable, what makes motivational interviewing a helpful intervention for this population, and particularly when to use it. And then I'll wrap up by talking about some of the foundational principles called the spirit of MI that could be applied to any work that you're doing, right? Because it's not necessarily a technique as much as it is sort of a philosophy of care or a way of being with patients. And so I'm going to talk about a little of that, which could apply whether you're trained in MI or not. So let's start with the stages of change. Why is it important to understand this model? How do you use it? So it's called the trans-theoretical stage of change model. It is an evidence-based model that's used to match people, sort of like where they are right now in their process of change with what they need and what they would benefit from based on where they're at. So it's not an intervention in and of itself as much as it's an assessment tool to help you determine where is this patient in their process of change. And so how can I match my interaction with them? How can I match my recommendations for them so that I'm not recommending or interacting in a way that isn't in alignment with where they find themselves. This model is not part of motivational interviewing. It was developed separately. That being said, it often does go hand in hand. And so a lot of times people will mix them up or will assume that they're coming from the same model. Motivational interviewing is actually an intervention or a type of intervening treatment model versus the stages of change, which is, like I said, it's really just a way of assessing for and conceptualizing where patients are. So this is a nice visual of the model, and then I'm going to go in and give you a little more detail about each one of the stages. I like this visual versus some of the other ones that I've seen that are linear, kind of like stair steps, because I think a lot of people in reality, they move through this model in more of a circular format than they do. So I guess think of it as a spiral staircase versus an escalator. Like when people are making changes in their life, they don't typically go from, I've decided I want to change, to accomplishing that change. And there's no going to a different level or a different mindset. So I like that this really kind of moves around in a spiral, and it also allows for flexibility and understanding that a patient could enter this process at any point. They don't necessarily all start in pre-contemplation and then move into contemplation, preparation, action. And sometimes when we're working with folks, they may be solidly in maintenance and then have a slip, have a relapse, going back to their old behaviors, whatever that might be. They don't always restart back at pre-contemplation. Sometimes they pick right back up in action. So it's important to kind of think about this as a dynamic a set of how people move through change, and to recognize that slipping back into old habits or old patterns is totally normal. It's actually a normal part of the process of change. And when people really establish, if you think about yourself, if you've ever tried to diet or exercise more, or maybe meditate regularly, like I'm trying to adopt some kind of healthy shift in my behaviors, oftentimes it takes slipping back into those old habits or those old patterns multiple times, and then getting back into that new set of change behaviors to really solidly kind of ingrain that process. So recognizing that relapse piece is a totally normal part of this cycle. So what are some of the things that we want to dig into to be able to make accurate assessment about what stage a person is? So pre-contemplation just means that they're not considering change in the foreseeable future. They may be experiencing negative consequences related to their behavior. They may be told by other family members that they need to change, or people in their life. It's not that they're unaware, or this concept of denial. They're not in denial that they need to change. They just aren't in a place where they want to make that change, or really they feel confident or able to make that change. So it's not something that they're considering. So that's pre-contemplation. Contemplation is when they move into actually thinking about, okay, I do want to make this change in the foreseeable future, not next year, but at some point in the upcoming future, I'm ready to move forward. Preparation is just the process of actually planning what those steps are going to be. So making those appointments, setting themselves up with a schedule, whatever it is that's part of that preparation. Action is when they've actually started to make the change. So it's when they've adopted that new set of behaviors, and those have been going on for days or weeks, right? So action means that they're actively implementing the change. And then maintenance is the period of time that goes beyond action. So once they've implemented that new set of behaviors and they're actively doing that on a regular basis in their life. So the importance of understanding where people are in these different stages is because it's really important that we match our interaction to where they are so that it's a good fit. So there's a common misunderstanding that people think when we're working with someone who's in pre-contemplation that we absolutely need to be using motivational interviewing. And there are aspects of MI or ME that have value, like a decisional balance, doing that fancy pros and cons list. There are aspects of that set of skills or techniques that you can use with people in pre-contemplation. But oftentimes, because there's no ambivalence, which I'm going to talk about here in a second, there's no real emphasis to want to make a change, it isn't the best fit. So what we really want to be focusing on with people in pre-contemplation is building that alliance and building discrepancy. So helping them to understand and really weigh out, like, what is this doing for them? What is this not doing for them? When people are in contemplation, that's when MI has the most benefit. So we want to wait until somebody actually has that ambivalence present to start to apply things like MI or ME. When people move into preparation, there isn't much that we need to do other than to help them do this in a reasonable, achievable way. So we can stop using MI techniques once we recognize they're in preparation, because they've already decided they want to do it. They're on board. They just need maybe some supports in doing it effectively. Once people move into action or maintenance, that's when our good CBT relapse prevention strategies are going to be helpful. So building up a skill set that they can rely on to maintain the change that they've made is what we're focusing on with action and maintenance. Again, MI is not going to be our best bet in these bottom three stages, because sometimes we can actually cause people to step backwards. And we definitely don't want to be doing that. So again, with pre-contemplation, they're not ready to make a change yet. So our goals are just to start to gently bring awareness of that problem, to have them start thinking about it a little differently, to maybe elicit ways that they've achieved things in the past that were really difficult, because it could be an issue of confidence. It could be less about motivation to change and more about, I don't feel like I can, or I have the ability to. So really just focusing on how do we listen for what their concerns are, what's going on in their life that is problematic, what is the current set of use behaviors actually doing for them, because it might be relieving pain, psychological, physical, it might be part of their social network, I don't know, but just listening and trying to get that information, and then making sure that we're communicating honestly without judgment, is building that rapport, having them feel that they can trust and be heard and seen and validated for exactly where they're at, without the pressure to make a choice, because, and I'll talk a little bit about how that can go the wrong way. When people enter contemplation and they're really actively thinking about change, but they haven't moved into doing something about it yet, that's when MI can be really, really valuable, because what we want to do is capitalize on that motivation, capitalize on the part of them that wants to to move towards change, and also just appreciate and accept that ambivalence is there, right? So it's okay that they're not 100%. It's okay that there might be issues around confidence. So we really just want to help them look at what is it that they're getting out of moving towards this change? How is this in alignment with their values, with their goals, their set of intentions? How do we help them address discord where they don't have to do it all? They don't have to do it all perfectly. So even a simple reframe from yes, but to a yes, and. So yes, I hear that you're really worried about how you're going to manage your pain without drinking this much per day, and look at how this is in alignment with the type of parent that you want to be, or those types of things where you can have them hold what they want in both hands, and it doesn't have to be an either or, where they're making a choice to let go of something that does help them at times, but also causes a lot of pain and difficulty at other times. And then you want to just be supporting that self-efficacy. So to really review, look at how they've achieved difficult things in the past. How can they kind of reflect on what helped them? What did they use to do that? Regularly be affirming their commitment, helping them to think through, is there a post-it note or a picture or anything that they can keep in their wallet or on them at all times to remind them why they're wanting to move in this direction, to really help reinforce that they have made this decision and how this is going to benefit them and the people that they love. When they're in action, our goal is just to help remove any barriers that there could be. So positive reinforcement for progress made, what might be barriers that could be causing some hiccups along the way. And then if they're biting off more than is really reasonable, helping them to kind of take a step back and think about what is achievable and setting themselves up for those little successes rather than focusing on the big, huge, when I'm recovered and my life looks like this. So helping them see all of the 20,000 steps in the service of that larger goal. And I think I already talked a lot about this, but just part of the benefit of using a model like this with the patients that you work with is it can be helpful to always be reminding it's okay to talk about relapse. That in fact, when we prepare people for this, that we don't, it's not like we're giving them permission. Relapse is something that's going to happen as part of any process of change. So it's just helping them to think about it from a normalized perspective, to see this as part of any change management. It's not a sign of failure. It doesn't mean that they have to go, into a binge for months on end. It's just like, hey, you had a slip. Let's look at that. What were the warning signs? What were the things that tripped you up? Was there any way that you could have seen that coming? If not, let's unpack it so you're better prepared next time, right? So being able to talk about it in advance and talk about it when it happens is one way of helping them avoid becoming discouraged and helping them re-engage with that change process without having to go back to pre-contemplation, to really get right back into action where they're implementing the changes that they want for themselves. So that's the stages of change model in a nutshell. Now let's move into some of the spirit of motivational interviewing. So I'm not going to talk about all of MI. I'm just going to talk about that foundational piece called the spirit. So why is it important to understand MI when working with this population? So I like this quote, which is, people are generally better persuaded by the reasons which they themselves have discovered than by those which have come to the mind of others. So when we're talking about making changes, whether it's substance use or diet or exercise or increasing or anything that's healthy, decreasing anything that's unhealthy, right? As human beings, we don't achieve and sustain lasting change when it's externally driven. When it's coming from our own reasons, our values, our why, it's much more likely to be achieved and much more likely to be maintained. So motivational interviewing taps into that. It's actually not a direct intervention as much as it's a set of skills and techniques and a philosophy that helps providers to talk with people about change, about the change process, and to collaborate with them where they're at on what is important to them, right? So it's a way of guiding and eliciting what they want to do. So we're not fighting with them. We're not trying to get them to do it our way. So it's a very different way of sort of being with patients or being with that person to help them connect with their why. Why would they benefit? Why do they want to do this? Why is this meaningful to them? And to be able to work with this lovely thing called ambivalence, which is just a natural part of the change process. I'm not going to go into this too much, but there's a ton of research that supports MI, particularly for people that are in that contemplation part in the stage of change, right? So they're ready to make the change, but I always imagine it's like walking a tightrope, where it's like walking along the top of a wooden fence, where on one side, they have all the reasons why they want to make the change. And on the other side, they have all the reasons why they don't want to make the change. And both of those minds are present at the same time. And so it's important for people that are in contemplation to be able to talk about that, to normalize that. And so there's a lot of research that supports whatever health behavior we're working on, MI can be valuable. So part of the spirit that's the foundation of this perspective has to do with appreciating that tightrope that people walk when they're in the process of making changes, and that's the ambivalence. So ambivalence just means of two minds. So having the part of me that really wants to quit smoking because I don't like the taste and it raises my cancer risk, and I don't want to expose it to my children, and then the part of me that I get, or the relief that it provides me, or the way it helps me wake up in the morning, right? So I have both of those minds present at any given moment when I'm trying to decide, and sometimes one mind wins out over the others, right? So that's a natural part of making any change, is we have these two minds present. So it isn't a lack of motivation. It's not that the person isn't motivated. It's that they have those two minds kind of competing and fighting with each other. So there's an old expression that says, when you have two dogs in a fight, which one wins? It's the one that you feed the most, right? It's the one that is strongest that wins those fights. So when we're dealing with patients who have this ambivalence present in their mind, part of our job is not to think of it as they lack something, but it's that we want to strengthen, support, and align with the dog that's in the service of the change that they want to make, right? So we want to be thinking about how can we allow for both of these things to be present and to be able to talk about that, and to avoid falling into what's called the communication trap, which is where we argue one side. When we start to get on a soapbox or a high horse about what they need to do, what they should do, what they have to do, and we're talking at them about their change process, that's the communication trap. And as soon as we start arguing a pro for something, this is why you need to do it, these are the consequences that you're experiencing, they are going to automatically start to defend the other side. And if you think about, if you've ever experienced this with kids and you tell them that they should do something, they need to do something, you can get that exchange. You might even have connected with this in your own mind, right? Like when you're telling yourself, I have to do this, I need to do this, I should, if you use that word, I should do this, you may have that other voice come online that starts to tell you why you shouldn't, or defending that other side, right? So that's the communication trap, or defending the status quo, which actually makes it much less likely that somebody's going to strengthen the side of their mind that's pro change. So what we want to do as providers, when we're honoring ambivalence, we're recognizing that it's there, we want to appreciate it and work with it effectively, is we want to avoid that communication trap and engaging in a behavior called the righting reflex. So that's that natural inclination that we have as helping providers to want to make it better for them, to want to highlight all of the benefits they're going to get out of it, all the consequences they're currently experiencing. Why is that such a danger? It's because it's that old quote from 1660, right? It's coming from our mind and not theirs. If we are talking at them about the change, it's going to be much less effective than if we elicit their why they want to make the change. So how we fall into this is because when we engage with the righting reflex with patients that are in contemplation, We believe the problem is they don't have enough insight, so they're unaware of why they need to change. They don't have enough knowledge. So if we just give them more education or give them more facts or more data about why they should change, then they'll do it. Or maybe they lack skills. So they have an inability or a lack of something, and that's what's preventing the change. And it could be that they need education or skills or insight development, but they're not going to need it in contemplation. They need that once they enter the action and the maintenance phase, right? So that's where a good kind of CBT sort of stuff can be helpful. But when we're using MI effectively with people in contemplation, we're not helping them when we focus on those things. What we're doing is butting right up into that ambivalence. So we don't want to focus on skills or providing facts or figures until we've thoroughly appreciated and helped them move through that ambivalence. Because when we hit it with, this is what you need to know, it just becomes this wrestling match. And what happens, it depends on the patient. Sometimes they may make a brief change, right, to either satisfy us or to satisfy someone else that's external, some other external benefit, but it doesn't usually stick. They usually end up reverting back to the old behavior. They may listen politely and nod their head and be like, yes, absolutely, I'll totally do that, but then go out and do whatever they plan to do anyways. They may actually actively argue with us. So if you ever have that experience where you feel like you're pushing and you're like locked horns in a conversation, you know you've bumped right up into that writing reflex. But at the end of the day, nobody benefits. And unfortunately, we have a tendency to blame the patient and say that they're not motivated, they're not ready, it's their fault, right? I did my job, I presented all the information, they should just change, right? So I think that that's an important aspect that the spirit of MI brings to the table, is helping us as helping providers truly help patients when that ambivalence is present. And there's a couple acronyms that can be helpful to hold on to that. So what should I do instead of the writing reflex? So MI gives us this thing called the rule. So you can spell out what does that mean. So the R is resist the writing reflex. So recognize it's there, do everything you can to not give into it. Work to understand your patient's motivation, because if you can get them talking about their why do you want this change? Tell me more about what this means to you. Then you're actually helping to strengthen the side of them that wants the change, to strengthen that other side of the ambivalence paradigm there. So understanding your patient's motivations and values, why they want it, really listening to them and reflecting back what you hear. So what I'm hearing you say is this. So what I'm hearing you say is that it's not that you don't want to make the change, but it's that, you're worried about what that's going to look like, or you don't have a lot of confidence in yourself because you haven't gone down this road before. And that's understandable. It's scary to do new things, right? If you can listen and reflect, you can actually provide a lot of that positive feedback and support that people need to feel the E, which is empowered. If they feel empowered and they feel like they have the ability, you've elicited that ability from them, then they are much more likely to be able to make that shift on a day-to-day basis. So that's why the spirit is such an important piece, and why we can use it even if you haven't been trained in MI. You don't have the top tier, which is the skills and techniques. But if you have the spirit, then you're using that rule. And you're also doing these three things, which is the ACE: acceptance, collaboration, and evocation. And you can apply this to any interaction with a patient and have some positive results. So when we're using acceptance, what does that mean? That means that in our interactions with the patient, we are working to convey that they have absolute worth, that there is no judgment over their choices, right? That we're going to treat them and care for them with that positive regard, that we are detaching from you should, you need to, you have to, and making it just very clear. Absolutely, that's your choice. It's your choice to continue using. It's your choice to continue behaving in this way. I can only help you to sort of sort through what your options are, and I'd be happy to do that, right? So it's just having that positive regard and conveying their worth in your eyes doesn't change regardless of their behaviors or their choices. And that's really important because there's a lot of research that supports when people feel genuinely accepted for where they are, then they become freed to actually make changes in the service of their own benefit, their own health. So even if we do absolutely nothing but just accept them, that can have tremendous power. Very rarely do we experience true unconditional acceptance in our life. So that has a ton of power if you can actually provide that for someone. The next one is that's part of acceptance is providing accurate empathy and autonomy support. So accurate empathy is part of that listening to really help reflect back the meaning, the values that they're sharing with you, to seek to understand that and be able to acknowledge that you understand it. This is what I'm hearing you say. This is what I'm experiencing. You tell me about why you want to do this or what's getting in the way. And then autonomy support is just acknowledging that same thing, that they can make choices even while using at high levels. Oftentimes we could make the statement that those choices aren't helpful for them, but it doesn't have to be something that interferes with the relationship that we have. So we can continue to affirm that we care about them, that we appreciate them, that they have the strengths, and that even just showing up today shows effort, right? So it doesn't even have to be about the change that they want to make as much as it is, are they taking the steps to be present, to even think about it, to talk about that change, right? So it's a shift from an authority perspective, which is where we're telling them what to do, what they must do, what they should do. So this kind of telling, instructional, educational focus, to really seeking to understand what their meaning is, to reflect that back, and to honor who they are, whether their choices are rational or informed or ill-informed, right? That we are just accepting them and recognizing they have autonomy and they have agency in their life. Collaboration is, if you think about it as we're on the journey with them, we're dancing with them, we're exploring instead of persuading, we're doing it together, and that they are the undisputed expert on their life. So they're going to be able to make a better choice, a better plan based on the details that they know than the plan we're going to come up with. So asking them to collaborate with us, to actually partner with us on how are you going to take this medication? What is the schedule going to be? What does your day-to-day look like, and where would this fit in versus things that we're requiring? You know, and this is outside of the realm of like maintaining safety in the clinic. This is just where we're talking about the types of treatment plans that are specific to them. And then lastly, evocation, which is where we're seeking to bring forth the part of them that is ready, that is capable, that doesn't need anything, that they actually have the strength, the capacity to do what it is that they want to do, because it's driven by their value set. And so our job is to pull it out, to put it on the table and look at it together and be like, oh, wow, there it is. You had it all along. You have everything that you need. You are completely capable. You are not broken. That we can evoke that mindset rather than feeling like they need something from us, right? That they're lacking in some way and we need to provide it to them. So when we're focusing on evocation, we're trying to reinforce and bring forth that intrinsic motivation, their values, their goals, what they have. So instead of feeling like this when we're having a conversation with a patient, when we're really engaged with the spirit of MI, it should feel like this. So that's all I have for this lecture. Are there any questions before we move into the case?